Me? Hi, I am Ellen Binder. I'm one of the faculty in geriatrics, and I have the pleasure of telling you a little bit about my father, for whom this lectureship was created in his memory. His name was Morton Binder. He was born in St. Louis, and after moving away and completing college at Yale and medical school in Columbia, he returned here to complete his internship and residency in internal medicine. He then served in the Army during the Korean War and returned to be a chief resident in internal medicine, completed a GI fellowship, and then entered private practice in the Maryland Medical Group and had a very flourishing practice and productive career. He was on the clinical faculty and was an attending physician on the inpatient service in medicine and the consult service in GI. And unfortunately died unexpectedly at the age of 58 from a ruptured aortic aneurysm. And as I look at his picture, and I am aging, I'm amazed at how young he now looks, which is a strange feeling for a child. But I wanted to tell you a couple things about him that I think in terms of his accomplishments that are particularly relevant today, and about him, which is that he really valued service a lot. He really felt it was important to serve the community, the medical community, and the community at large. And in the late 1960s, he was very concerned about the lack of access to care to poor African Americans in St. Louis. At that time, the availability of primary care was at our city hospitals, of which there were two, and the clinics at places like Barnes, Jewish, St. Louis University hospitals, and a community clinic called Grace Hill, which is now evolved into Affinia. But he was asked to partner with a community group that was very concerned about the decline of their community and the lack of care. And he developed a community-based clinic using a really innovative community-based model that I cannot go into, but recruited physicians from Barnes, Jewish, and St. Louis University to staff this clinic voluntarily for several years. And this was in the period before there were federally funded clinics, which evolved in the 1970s. And then I think that's why this clinic was no longer needed, but pretty remarkable. In the 1970s, he became very concerned about the lack of quality of care for patients who were at the end of their life and dying, and started what was the Barnes Hospice Program, which was the second hospice program in St. Louis, the first home-based program in the region. And at the time of his death, it had really just launched, but it has now flourished. Patrick is doing an amazing job of leading it into the future. So Dr. Quest, I think that the focus of your talk really embodies a lot of what was important to my father, and I'm so thrilled that you were able to make it today, and welcome you and look forward to learning from you.
Thanks so much, Ellen. And now just for a really brief introduction to our amazing speaker, Dr. Tammie Quest did medical school at the University of California, San Francisco in 1994. Afterwards, she did an emergency medicine residency. And during that time, saw some of the gaps that we could do a better job helping support patients with serious and terminal illness that come into the emergency medicine space. She's a full professor at Emory, leads the palliative care program, is a professor of emergency medicine and geriatrics. I think you're running out of things to be professor of, Tammie. But she developed nationally the curriculum for emergency medicine residents that really helped to shift the paradigm and bring the importance of supporting these patients and pearls of palliative care into, it's called EPIC emergency medicine. She then went on and has tackled countless issues in supporting vulnerable communities. She won the Richard Payne Award, which our American Academy of Hospice and Palliative Medicine, the highest award for diversity, equity, and inclusion research. And then has gone on to become president of our 6,000 Physician Academy, and has just done outstanding work showing the need to support all communities from ER docs to across the globe. So Tammie, we are so excited to have you here. Without further ado, Dr. Tammie Quest.
Thank you. All right. So appreciate the invitation, and really Doctors Bender, I got a chance to spend time last night with Dr. Bender and just hearing about all the incredible things that her family's done. And so legacy and vision are very important. And so I'm here as in the spirit of legacy. And hopefully we're gonna leave here together with a vision of a stronger place and a stronger world. I believe that the events that we've been through over the last 5 years, and I will say, you know, we sort of have a time clock, but you know, things were not great actually before we had a pandemic in this country, and really horrible things were happening to people and continue to happen to people of color and inequity. And so I think really in medicine over the last 5 years, because of I think a lot of the work I've seen gaining steam, really I would guess say over the last decade in the DEI space is really, I think, our hope for the future to make medicine stronger and to right some of the wrongs that we have perpetuated. So we're going to talk about inequality and inequity and serious illness care, and I'm going to touch on multiple aspects of that. We're going to work through a case or series of cases. I have no disclosures. I'm not on the payroll of anybody or anything. I still have time. I'm in my about to be 25th year of being faculty at Emory, and so I am taking you know, donations and trying to get on the payroll of something. So, but I don't have anything here. I've managed for a quarter century to stay off the payroll. So we are going to talk today a little bit about uncomfortable things. We're going to use words like racism, structural racism. We're going to talk about inequity. And you know, I don't have a financial disclosure, but there may be some discomfort in the room. And I would like for you to just stay uncomfortable with me for just a little bit. It's just an hour. And then you can go off and decide how you want to continue to challenge that discomfort. So we're going to talk a little bit about social determinants of health. We're going to talk about equity. And we're going to really, I'm a palliative care physician. I'm a lot of things. It's fine if you want to go ahead and have a cardiac arrest right now. I'm pretty good for that too. I can help you out as an emergency physician. Or if you have a serious illness, I'm happy to support you in symptom management and serious illness care. And when I think I chose emergency medicine because I just wanted to help people. And I met with a lot of folks yesterday. Patrick has assembled an incredible team and many familiar faces now in the room that I didn't actually know before. Mark Williams and I go way back. And we could tell stories as we worked at Emory together 25 years ago, and really side by side. And I think that an emergency department is a place where we see inequity play out every day. And I was always, as an emergency physician, drawn to just helping people, and had a deep observation of inequity, and actually how much people really blame people for going to emergency departments, right? There's a lot of blame and judgment if you end up in an emergency department. And actually that's sort of a position of privilege to to actually be able to blame people for showing up. Why are you here for foot pain or something and you couldn't have done? And so I hope we know more about appreciating the social determinants of health that before we stay in a judgment space. So I want to talk about Mr. S. We're going to do a few cases. And Mr. S is a 68-year-old African-American male. He has end-stage heart failure. He's on home inotropes. He's not a candidate for transplant or LVAD due to morbid obesity, right? That's quickly becoming, the number one, cause of death in America. He has tried to lose weight for the last 2 years. He's been unsuccessful. He's not a candidate for bariatric surgery due to his advanced heart failure. She's actually like in a cycle of despair, right? Of medical despair. He suffers from chronic renal insufficiency at baseline. He's not yet on dialysis. He's repeatedly told his cardiology team he wants everything to be done. The clinical team fears he is going to die in the hospital in the ICU with non-beneficial therapies at end of life, and that he will have a, quote, terrible death. Raise your hand if you've seen somebody like Mr. S before, right? And thought these same things, right? This is really, Mr. S is obese. We have very little compassion for people with obesity, right? We are trying to transition that, hopefully, for people to understand more that it may be just more than I did too many, trips through the drive-thru at McDonald's, right? We're trying to understand that more. But there's a lot of sort of, blame here and bias and all sorts of things that happens. And even if we, it comes out in very, small slights, of these patients. And so here he is. So as we think through the social determinants of health, and I'm going to try to see if I can, let's see, I've got my Zoom screen. I'm going to see if I can minimize it. I don't know if I can, because it's over my slide here. Okay, I'm going to just move it. You can't see that, but oops, I just did something. Oh. Okay, I'm just going to leave it right there. Okay. So, and I'll turn this way. So essentially, what you'll see here, the Kaiser Family Foundation has done a lot of work actually in equity. And there's some really nice, I think, infographics like this, if you will, that really show. So what you see here is we talk a lot about what we don't want people to have at the end of life. And yet what we actually don't really think about is what was the course of their whole life and their disease trajectory and how we got here. So as you can see here, there are 28 health measures, and just this graphic kind of shows in of these 28 health measures by race, who did, was there no difference, better, worse, limited data. And what you can see here is along the course of illness, hopefully this is a pointer, maybe not. Oh, is it? Yep, there it is. Okay. That in 19 of 27 chronic conditions, Black patients far worse along the course of that. So as you think about how Mr. S got here, right, all the things that might give him advanced heart failure, right? So cardiovascular disease, maybe diabetes, maybe uncontrolled hypertension, it gets to be this, all of a sudden you're in this end of life bucket, but actually over the whole course of your illness, you've really not stood a really great chance. And as we see here, American Indian or Alaskan Natives, Hispanics, and Native Hawaiian or other Pacific Islanders, you can see also are faring worse over the entire sort of course of their chronic disease management. So when we see Mr. S sort of show up in this space, it's not so much that he just one day showed up like that. It is that there's been a whole trajectory, and we are fairly sort of judgmental in medicine about how people got there. So he's had the disease of obesity, he's probably had the disease of hypertension, he's had many diseases. And so the question is, what sort of things were done along the way to have these conditions modified? And it may be that that he did not have the same opportunity. So, hold on. Picture guy here. Okay. So what we also know is that health disparities are really driven by socioeconomic and inequality. And so you see here, as you're thinking about your own community here in St. Louis, the ability to have economic stability, a neighborhood and physical environment that is safe, education, food, community safety, and a healthcare system that works for you is really paramount to those chronic conditions that we and faring better. And so what we know is that race and racism can really is the cross-cutting nature. Okay, so I'm a Californian by trade, and people have a lot of judgment about the South and all this. My husband was born and raised in Berkeley. He was born in 1964, and his family was the first Black family to break the covenant. Yes, there was a covenant against Black people living in Berkeley, and the neighborhood protested in 1968. Now, this is Berkeley in the 60s. They protested against his family, my mother and father-in-law, buying a house in Berkeley. Okay. Now, as you can imagine, right, that's probably not what you're thinking. So how is that? How is his life different because he was able to live in a certain neighborhood versus not? And so we have systematically and structurally in many places in this country, some of them more highlighted than others, created an inequity that really shapes the lived experience of people. So when we think about equality, you often hear people say things like, I treat all my patients the same. Actually, that's a problem. So if you actually are treating all your patients the same, that's not a good look, as we say. As we know that if you're treating everybody, oops, going the wrong direction, sorry guys. If you're treating everybody the same, it is this idea that if you're starting out with less and we're treating everybody the same, that's probably not going to work. Yet, our healthcare systems are often focused on, as a marker of quality, standardization. And that standardization is really good when we focus on the standardization of the outcome. But when we focus on the standardization of the resource needed to get the outcome, that is problematic. All right. And I'm going to get into the Medicare hospice benefit in just a bit. It is a standard benefit that is not very flexible. And so we are expecting a standardized outcome with something that does not allow us to adjust for inequity. And so this idea of health equity really is giving everyone the resources they need. And so as we talk about standardization and quality and outcomes, we should have a standard idea for the quality outcome. However, the resources needed to achieve that standard, we need to think very, very carefully about how we're going to achieve an equity based on the fact that we are in an inequity situation. So when we look at the concept of how is the structure set up, so I'm going to just use my husband in Berkeley in the 60s and his family as an example. A covenant, a restrictive covenant, is structural racism. I mean, there's just no two ways about it. They wrote Black people could not live in the neighborhood. Okay. And so to spite them, once they broke the covenant, my in-laws not only bought one house, but they bought two houses. Okay. Just to kind of like be a little over the top. okay? And so this idea that just by virtue of your skin color, you are not able to have equal access to housing despite resources is the definition of structural racism. So when people say that that's not a thing, it is a thing, okay? And it was a thing, and it in some places still is a thing, and whether it's written down or it is practiced are two different things, right? So some of it is overt, some of it is covert, and we're going to talk about that. So the American Academy of Family Practice talks about structural racism, a system that categorizes people based on race, color, ethnicity, and culture to differentially allocate societal goods and resources in a way that unfairly disadvantages some while without merit rewards others. Access to food is not a small point. If you live in a neighborhood that doesn't have a grocery store that sells produce, how are we going to tell somebody that they need to change their diet, right? This is a huge issue. So when you look at geoanalysis of social determinants of health, the ability to have access to a grocery store is not a small point. And if you go to probably some of the most disadvantaged places in this geographical area, which I don't know very well, it would be incredible for you to just think about how many grocery stores and can I walk into that grocery store and what's on the shelves of that store. In many places, it's going to be non-perishable items, canned foods, other things. And as you can imagine, for Mr. S, this is not going to be a good thing. So as we think through housing, education, employment, the criminal justice system, access to food and healthcare, really our society has a demonstrated track record in all of these areas of inequity and in racism, right? So we know we will not go through the Tuskegee experiment today. I will mention it because I'm just going to say it. That is, healthcare has been participant in structural racism, and things like trying to prove, the biological differences in Blacks and whites. I mean, this is really the underbelly of where it is. The institution of medicine spent much of its early lifetime trying to exclude Black physicians. That was actually, kind of, if you look through the history of trying to become a Black physician. So whenever I hear somebody say, my grandfather was a physician, I just bristle just a tiny bit because it wasn't an option for my grandfather. That was not going to be an option when they were 16, 17, 18, coming up and thinking about things. And so this idea of having generations of physicians in your family is privilege. And the reason that African Americans do not have generations of physicians in this country in their families is absolutely due to structural racism. And so when we think about that pipeline and we think about, why do we need to try harder and what, because we didn't start out the same. So let's go to dying. Look, anybody want to die in that room? Looks pretty good to me, right? I mean, looks a lot like where I stayed last night at the hotel. Thank you. Thank you all. Thank you all. I was trying to move in, but they told me I had to leave this morning. So in any case, this looked pretty good. Would you want to die in this room? Raise your hand if you want to die in this room. Okay, Mark, pretty good. Yeah, I think it looks pretty good. Okay. What about this room? Anybody want to die in this room? All right. One of the things that we've constructed in this country is an incredible fascination with dying at home. And we are incredibly fixated that dying at home is what should happen categorically. Why would you want to be here in the hospital? Why don't you want to die at home? Why don't you want to go home? And I would say that this is, home is what you make it. I understand that. However, what are some of the feelings that this might, what do you feel like this room is? Just give me a feeling, throw something out. Sad. Dr. Bender, why does it seem sad? Lonely, empty, dirty, uncomfortable. We've got some buckets on the floor. Maybe the ceiling is, you can imagine there's the drip, drip, right? It wasn't particularly warm and sunny outside today, by the way. It is 72 in Atlanta. I'm not recruiting, I'm just telling you. But in any case, this is, we're fascinated with the idea of dying at home because by and large, our homes don't look like this. They don't look like this. And I'm not saying that Mr. S doesn't want to die here and he wouldn't want to be at home. I'm just saying that, I'm sorry, the back button. Oh, I see. Maybe. There we go. I'm hitting the wrong one. This, compared to this, may not be a bad thing, right? You have people who can come take care of you. Food is delivered. We don't know. I mean, how's he going to get food if he gets immobile and he gets in the bed, and this idea of caregivers, and maybe somebody has to go to work. Okay, so this is really just this idea that next time you get ready to, you're wondering why somebody doesn't want to go home. I just want you to just pause for a moment and realize that this idea of going home, we often see that through our own lens and how we feel about our own homes. And we may not be, we don't know, maybe he's, hasn't paid his rent and doesn't know if he's going to be able to be there for more weeks and you're trying to send him home. Okay. So let's kind of, that's the first case for food for thought. Case number 2. All right. Workplace violence, racial slurs. Okay. After death of the patient. This is a true case. This happened not too long ago to our nurses. So white patient dies in our care under hospice. And I use race here purposely. There's a white husband. After the death of the wife, aggressively approaches our African-American nurses and our East Indian physician, blaming them for the death of his wife. He screamed multiple explicatives, just rolled right off like it was nothing, told them to go back to Africa and India, and just really wouldn't stop, actually, was in full force. I will tell you, I've seen this responded to in a number of ways. One way I have seen is he's grieving. He's grieving. We need to support him. He's grieving. Okay. I have seen very bad behavior that is very offensive to many people be excused and supported in the name of grief, despair, and sadness. And I want us to really think about that for a minute. So how do we react? How do we support our colleagues who are undergoing that? So this idea of sort of, socially acceptable racism is really kind of, we've really gotten very comfortable, unfortunately, with all kinds of things. And so we have very clearly socially unacceptable things. So when people are really, lynching, hate crimes, blackface, the N-word, swastikas, neo-Nazism, burning crosses, racist jokes, slurs, the KKK, okay, these kind of things, people are like, oh no, that is out there. Racial slurs, actually, I would call it, is kind of on the line. Like, people sometimes will tolerate horrific language in the name of all sorts of things. And really this idea of this, what's socially acceptable, right? You don't sound Black, make America great again, prioritizing white voices as the experts, treating kids of color as adults, right? They They don't get to, they've got to behave. They're otherwise, completely, out of control or whatever it is, higher standards placed to children of color. And we've seen this actually in the pediatric literature. I think that this iceberg, when you have these sorts of episodes, bring things up for the team who are persons of color, that all of these things are really stirring underneath. And you get these sentinel events in the workplace, and there's that event, but it's really the iceberg of what people are experiencing and the heaviness that they're experiencing. So let's go to another case. So the patient called me colored girl. The senior doctor training me said nothing. So, Dr. Okwirku here is a columnist and a psychiatrist, and I would point you to her column, and she wrote this. A patient called me a colored girl 3 times in front of the attending physician. The doctor did not correct the patient, nor did she address the incident with me privately. Despite all the other positive interactions I had with this teacher, her silence in this circumstance diminished my presence. I wondered if she thought of me as a colored girl too. Looking back, I don't regret my timidity. It's what I felt I needed to do to survive. But I feel angry and frustrated that my mentors in the medical profession didn't raise these issues themselves. Diversity and inclusion initiatives challenge bias in the abstract. Checking bias in real time with real people is much more challenging. Maybe they didn't notice the bias. Maybe they didn't feel it was important enough to talk about it. Maybe they didn't know how to talk about it. They should have. And this, I think, is a really powerful photo, artwork there that you see here for that. And like I said, she's talking about racism in medical education. She is a young physician, so this isn't like ancient history that this happened, that she was called colored girl in rounds. And if you look at just symbols that bring out all sorts of emotions in this, I think it's just a really incredible piece. And I'm going to point you to read more about that and hers. So when we have these sort of situations, why don't we confront them? I would ask some of you why you think we might not confront them. Given that I got a full house today. Lovely. Yes. Yep. We're afraid or we don't know what to do. Actually, in medicine, we're pretty good at becoming quiet when we actually don't know what to do about something. The speechless moment. Yep.
Not knowing how the person is going to take whatever it is.
Yeah, so fear. Yes. Oh, no, you were just messing with your hair. Okay. Anybody else? Any other ideas? Yes, please. Up there, all the way. Huh? Right. So not knowing a discomfort with the person there, and what, not only just how's the person who said it gonna feel or take it, or what do I say, but then it creates an awkwardness in the team. Yes.
Communicate family, like there's an expectation that our job is to make people better, or that we complete them, press meetings for it, all that stuff. So we're afraid to react to when they are objectively being, saying things they're not supposed to, being racist, all that stuff, because we have expectations of always trying to please them.
Thank you. The customer is always right. That's absolutely an emphasis in medicine that we've really gone toward, right? So reasons, thank you for bringing some. So in Annals of Internal Medicine, Dr. Jane wrote this. we sort of think maybe we should take the high road and ignore it. We feel like we have a duty to treat and keep going. We might think that we need to be big enough just to, that's ignorance, and we're just going to really ignore that. We may intellectualize it, like maybe they're delirious or sad or upset or something with the underlying medical issues, and then an accommodation of patient cultural norms. That's just kind of how people from this area, this neighborhood talk, right? Oh, that's normal. I've seen this before. That's kind of how they are, right? And I think that, this is the reason that I pull an old study is because this has been out there for a while. It's not like it's new information. We have a whole body of literature. So some unique aspects of the customer always being right. Really, we know that patients are under a stress experience. We know also that it is likely for many patients, they've actually never seen anybody that doesn't look like them, right? They actually don't even know how this works, right? They may come to a tertiary, quaternary referral center, and this is the most, like, they've never met a Black person. I mean, there are absolutely, you talk to people and like, I didn't know a Black person until I went to college. I mean, literally, like, not a single, person of color or any other race or ethnicity in their, high school or growing up, but communities, right? So all of this zip coding that we have does have the effect that people actually may not grow up with folks. And so, all of that, be that as it may, is we have to help patients have when they're exposed to different situations or scenarios, what I would say have a functional coping versus dysfunctional coping in a setting that they may or may not be familiar with. So what happens when we don't address it? Well, if you're the person on the outside of it, or you're the out of the joke, right? If you're the person of color, you feel horrible. The other people around you don't feel too good either, right? So if Paul and I are together and something is said and Paul doesn't react to it, I'm feeling bad. Paul's feeling bad that he didn't react to it. He's worried about me. I mean, you can just imagine this is just a really, horrible cycle. And as we talk about contributing to burnout and compassion fatigue and all of these things, there are consequences by not leaning in. So what sort of things could have been said by the attending? Well, one response, let's pretend it was me. I noticed that you called our student doctor team member colored girl. Her name is Tammie Quest, and she's a medical student and a valuable member of our care team. In the future, I would ask that you call her by her name, Tammie. Okay? If you don't think you're going to be able to do that, I'd be happy to talk with you privately about why not and how we can move forward. Not so bad, right? You have to have in your mind preparedness that when I get into that situation, what's my script going to be? What am I going to say? How am I going to be an upstander in this moment? We don't have to make a scene. We just need to correct behavior. We need to name the behavior. We need to model something. We want to give the patient another option, right? We want to call it out, and we want the patient to commit with us. And we want to model in front of others how it is that could be done when they experience that sort of thing. So our world is full of prejudice, a preconceived opinion of another person, not based on reason or experience. Prejudice actually can be positive or negative. I can have this idea that I might have incredibly positive feelings that are completely unwarranted toward Patrick, and I have a lot of positive feelings for him. I believe that there's some really great things, but they may not be warranted, right? So some, but not all prejudices are racial in nature or have racist outcomes. And prejudice in and of itself is unlikely in and of itself to impact people as negatively as racism. So prejudice is widespread. Racism is another level, okay? And so racism is actually about belief. It is fundamental belief that race is equating to particular traits, superiority and unequal power distribution. And people learn their ideas about race very early. They learn them at home. And, I believe that it's not, really the idea of being an upstander is when you can go, confront your uncles at the family reunion or something about racist remarks. Because when you get to the family reunion, they might just let it rip and you're thinking, oh, that's not how I feel. But can you actually kind of, be an upstander or bystander there? And so we see that racism is really about belief, and those beliefs are typically formed at home before people interact, and they are very, very, very hard to change. So I actually, anybody recognize this? Okay, where do you recognize it from? It's on the wall on your floor. I took the picture yesterday, okay? And I was looking at this, and we have a lot of things. So I looked at this and, oh, that looks great. It's from Harvard Business Review. And it talks about, can I trust this person? Can I respect this person? Like, these are all the things that need to happen, for this, leaders, and, warmth, competence. Before people decide what they think of your message, they decide what they think of you. Leaders who project strength before warmth can run the risk of eliciting fear. I've been told that I am that I lead from the position of command. So I have a lot of risk in leadership. This paradigm is really not on the side of people of color, actually, right? This concept that I'm going to immediately need to feel warm, like this idea of warmth and good feeling. If you fundamentally actually don't have warm feelings about people of color because of whatever it is, their opportunity to be seen as a leader, at least in this paradigm, is automatically jeopardized. And so actually, when we think of, if you are part of a majority group, this is nothing to you. But if you are part of a group for which, people may not just immediately electrify toward you based on appearance, based on mannerisms, based on anything, actually, some of our paradigms, as we think through them, how are we accounting for bias and all kinds of conscious and unconscious bias here? So just thinking critically about things. So, we were at dinner last night, and I asked somebody where they were from, and I said, I just asked you where you're from. That's a microaggression, actually. And so commonplace daily verbal slights, whether intentional or unintentional, that communicate hostile, derogatory, or negative attitudes. I have often been told that I sound white, or people they will talk to me on the phone, and they don't know that I'm Black, and then they will see me, and they're like, actually, they've stopped saying it recently because they realize that's probably problematic. But many, many, many times in my life, I've been told that I was white, and actually, like, even the Valley Girl. That is not, I don't know any Black Valley girls. So I just believe that that's kind of actually a slight, like, oh, I'm kind of surprised that you could be Black and have diction that sounded in a different way. I mean, there's all kinds of things in there. It's really a microaggression. So what are some of the microaggressions that sound like, that normal conversation? Where are you from? Where are you born? You speak good English, you're a credit to your race, you're so articulate. You think people do not say these things to people, but they actually do. I know this is unbelievable. When I look at you, I don't see color. That's actually very insulting, because we know that actually people do see color. And so the idea, I know that it sounds like it's an alignment. America's a melting pot. The immigration story is a really hard one for African Americans, because immigration for other immigrants to this country was voluntary. And African Americans got here through a legacy of slavery and chains and capture. And so when somebody starts talking about a bootstrapping legacy immigrant story, that is actually triggering for many, many African Americans. It's not that you can't tell your story, but just understand that the parallel story for African Americans is one of death, violence, and horror. And yet we all are here. So the concepts that we just melted into this pot, no, that's not how it happened. And so it can be very marginalizing to hear that. So we all got this one, right? Macroaggression. That said, on hot mics and, all kinds of things, it's not like people that aren't running around saying this, right? So I just want everybody to, understand that this is still happening. So I'll point you to another study in the Journal of Internal Medicine about faculty and trainees' experiences with micro and macroaggression. And this is with 14 physicians, 5 faculty, 2 fellows, resident students. These were semi-structured interviews, and they were able to share their experiences of this. And they talked a lot about the immediate impact of microaggressions. And I think what's more interesting is really sort of some of the late effects. But what are the responses if you read through the study? People become actually numb to microaggressions. So actually earlier in your career, you're sensitive to it. And then actually after you've heard it for a while, you basically are just kind of over it and it feels kind of normal. Actually, it's just the way people talk. Earlier, depending on your level of trainee, you are much less likely, if you were in a position of being evaluated, to actually say or report discomfort with a microaggression, because you were actually, connecting that to maybe if I say something, somebody may not, grade me the same way. And that is very common in African-American students. Specialty dependent institution, time factor, right? Like you hear these things and you just have to keep it moving because we're too busy to deal with it. And then, how do we respond? Well, we might talk about humor, diversion, clarifying questions. We may just say the patient is ignorant, or that doesn't make sense, or whatever it is, and kind of keep it moving as though we've dealt with it. But unfortunately, we have not. So as they talk about this, what do they notice? Well, a noted lack of institutional policies to support a response to aggression, so microaggressions. So that was a macro, what was happening with that patient in hospice and that family member, that was macroaggression. However, I will tell you that, and we have 0 tolerance for that. We called, just so you're wondering, we called security. And we told him that was a form of workplace violence. And if he didn't calm down, he was going to be removed from the premises and or arrested if he escalated to a more violent posture. I realize that his wife is just dead right there, but yeah, and we're not going to do that. Okay. And we have a very strong workplace violence policy at Emory, and we don't tolerate that. And I don't know what your policy is here. Maybe you also have one if somebody were to go off the rails. But what you might want to know, if somebody goes off the rails, what are we going to do? Okay, homework. Okay, coping. So how do people cope? Well, they talk to their family and friends because maybe they can't talk to people at work. And who do you report, off the rail patients to? Right? Do you file a safe report or whatever it is? What is the culture around the off the rail patient or faculty member? Right? Who's saying or doing things that are not okay. And so this idea of how are we going to clean up our culture, deal with it, and feel like there's not retribution is not a small thing in medicine. So a last case here. So we have an 82-year-old male who's admitted with chest pain, new effusion, worsening pain along the ribs. You pull the gown down and you see this, right? Everybody's got a little body art working on. I'm still going to try to get some before I die. Still just trying to think about what I want. I don't want this, but some people have this. Okay, some people have this on the canvas. Now, it's triggering, if nothing else. Okay, triggering. We don't know actually what it means. We may not want to ask the patient what it means, but it's triggering nonetheless. We saw that he's increasingly frustrated. Just because he has this doesn't mean that, he actually holds these views. I know that's, we have to kind of neutralize that idea if we don't have a conversation. But then he starts really escalating and talking about foreign doctors, not being able to understand his doctor's diction. He's got an accent. He's asking for white nurses. He's calling the Black nurses monkeys. He's doing these things. He's saying that to the white nurses, by the way, not the Black nurses. And then, of course, and then he sort of throws out the N-word of the bomb. So I think that, the idea of when our patients are really exhibiting this, like in the hospice, I think, oftentimes people are communicating their prejudices, but may or may not be racist. I think these visual or environmental clues can be very triggering, but may actually not be what we think they are. So if we actually get to the point in medicine where we can start having real conversations with our patients about, please, can you share with me more about what your tattoo means, and feel like that's okay to do. And then, we can't really make these assumptions in all fairness, yet we probably do need to have a conversation, and we do need to know what the lines of behavior are, and what is okay and what isn't, and how is our institution going to back us up. And oh, by the way, what if it happens to be somebody in power, like an administrator or an attending, who's supposed to be leading others, who has, multi-million dollars of grants or something, all of these things. How are we going to police all of that? So it matters. We need to be able to name and manage it. We need to be able to neutralize its impact on our teams. We need to know what our policies and procedures are. And we need to be very, very comfortable that we are in a place that we can focus on this. I'm going to ask Patrick about time. So, or are we at, it's right at 9. We're finished. This is finished. Okay. So I'm going to just throw a few considerations of end of life. So, do we have the right measures at end of life based on a lot of things, right? What are we measuring? We have this enormous fixation on home death. And I think that we really need to think about that. And I know there's a lot of push not to do that because it's going to mess with length of stay and all sorts of things. But I think we need to think about that. We need to think about the Medicare hospice benefit. We need to think about how we communicate with patients. This is a famous study in our field around physician body language with dying patients. And what was said, the verbal was actually the same, but the nonverbal was very different. People stood by the door. They didn't have eye contact. They did these sorts of things. I'm going to implore you to look with this a bit with racial discordance with patient care. We need to think about how we talk to patients about their experience. And we're starting to do that more in medicine, to be able to ask people so we have Vital Talk, or, y'all have been doing Vital Talk. Y'all, see, there it comes. I'm a Californian, but I got y'all. Y'all have been doing Vital Talk. And we're going to get to, at some point in our field, the Vital Talk, to be able to have conversations with people about how social determinants of health, including racism, have affected the long view. Remember, there were 27 conditions. What has your whole illness experience been like? Do you feel like you got everything? Do you feel like you have the best care? How does that impact how you feel now about the decisions you're making about your health care? We haven't figured that out yet. Hospice utilization is really very, very tricky. There are practical and functional elements of the way the Medicare hospice benefit has been constructed that require the patient to actually buy into to sort of this idea of equity. We're all playing on the same field, or equality, that we're all playing on the same field. And there are things like focus on family caregivers. That assumes you have a family and that they don't have to work to pay the bills. Focusing on care at home, it assumes you have a home. The care model is nursing versus physician focused. That actually really assumes that I'm going to trust that a nurse with my level of complexity, can take care of me as well as a doctor. And I haven't seen enough doctors in my life, and I'm wondering now why I'm only seeing the nurse, right? And this idea of dying at home, and trust and all of these things, I believe that the Medicare hospice benefit in and of itself is actually helping perpetuate inequity at end of life. And Patrick's going to fix that, and team. So EMS response times, right? So do I get help if I call? This is a study, I won't go through it, but really, if in cardiac arrest, if your lived experience in your neighborhood is that people collapse and you call 911 and people don't actually come the same, the idea of actually having, as you can see, the orange line is what your in cardiac arrest on-time response theme times are in low and high income neighborhoods. So the idea that you're telling me that I'm going to call a nurse to come out to my house when I'm dying and expect them to actually come, we actually don't know if that really happens the same for people. We know in cardiac arrest, it doesn't happen the same. And you can see here the times, the resuscitation times, right? So anoxic brain injury, time to anoxic brain injury that's probably reversible is 15 minutes in the field. And you can see here that in low and high income neighborhoods, the response times are not the same. So the idea that now somebody is anoxic, status post cardiac arrest, the family wants trach and peg, maybe what they're remembering is that actually we called when he collapsed and nobody came, and you tell me now they didn't get oxygen, right? So what kind of things would I like to see? I'd love to see something about a true study about hospice response times in low income neighborhoods, right? Oh, I was fearful, it was 3 o'clock in the morning, I was worried the gang was going to get me, whatever it is. While the patient is having shortness of breath, active dying, all these things, we don't have any data in our field that actually shows that we are not, that we are responding to people the same. And I would love to see that data. So in summary, I'm going to say that in clinical settings, there are a number of factors. We've talked about some of those, prejudice, microaggressions, macroaggressions, racism. I've shared some personal experiences in my own family, and I could share many, many more as a Black woman in medicine. And understanding that teams, all of you, we can all get better. And we certainly don't have this figured out, but it's not just good enough to know that it's happening. We've got to now take the action step. We need to ensure that we should consider these displays of racism in a healthcare setting. We should consider that workplace violence, actually, that is occurring on the part of patients. And we need to be thinking about, because people that is an attack on their personhood. And we need to be thinking about how we're going to respond to that. And we really are at the zero, kind of the zero tolerance for us. And at the risk of, upsetting the patient. It's fine. We're going to be fine. You can stay here. We can all take care of you, but let's talk about the rules of the game. And that's just how this is going to go. And in clinical settings, I think, we want to be thinking about how we're going to be anti-racist. And there's some resources out there in anti-racism that I think are, really incredible. For you all here, I want you to look at this resource. How many people know about Forward Through Ferguson? Anybody in here? Okay, a couple of people. Just an incredible initiative. More people in this room should probably know about this, where they're focused on community engagement and equity in your local community. And I think that just getting out into the community and out of the little tunnels and walkways and figuring out what's out there is going to help not only you, but your patients and families and the community that you're serving. So I did get to the end. You do get to have CME. I did tell you we were going to get a little uncomfortable. Okay. I appreciate you all being with me on this courageous journey to stand here and talk about hard things. And I will get out of the way of it's high up. I'm not in the way. I'm thinking I'm in the way, but I'm not in the way. Okay. and appreciate the opportunity to come and to share in Dr. Bender's legacy of reducing disparity and promoting equity. So thank you.
Dr. Quest, thank you so much. That was a really terrific talk. We're a little tight for time, but I think for those of you who have time and can stay, we can address some questions. I have one question,
Yes.
and I want to, first of all, thank you, for giving this talk. It is a difficult talk, and you did make everybody uncomfortable, and that's the right thing to do, and I'm appreciative for that. So the issue about how you interact with patients and families that are racist and inappropriate and unprofessional and potentially violent, what do you do in terms of hospital policies and procedures in terms of either managing those patients beyond, calling security?
Yeah. So that was an extreme example of security. Every day, there's a workplace violence dashboard essentially that's been developed, and so people can report incidents so that of different things, not just that's the extreme kind of piece of from workplace violence. It starts with a conversation, right? So the unit, the nursing unit directors and medical directors are committed to talking to patients and families about, we're not going to be able to change patients' beliefs, okay? When we're not trying to change beliefs here, because we can agree that we're going to believe different things. What we can focus on is behavior modification, right? And so setting the ground rules that say, here's what we're here to do. We're here to take care of you. We're here to make you better. This is a place of healing and support. Here's what we need to have our team be able to best serve you. And here are the ground rules, right? So of course, when somebody skips all the way from the ability to coach, right? So that's how we start with all deviations in behavior. We start with coaching if we have an opportunity. Sometimes people just blast through the opportunity for coaching and just are, full bore. Then you're going to have a more, I think, you need to have a prepared response for that, right? So we have to have a coaching response, and we have to have a prepared response, and you have to have people who understand how to coach and deal with that behavior, and that we're not going to just dismiss it, and there are expectations in the organization. I would just say that, it's a range of responses, but it starts with the organization deciding that it's something we're not going to tolerate, and so we are going to figure out a way. So.
Tammie, when you are coaching fellows or other non-palliative care providers out at this talk, and looking at different how you yourself do it with a white family and a family of color, are there any ways you approach it differently, or how do you coach,
Right. So I think that, this idea of, and I don't think we have anything perfected. You can try a softball question that says, do you think you've gotten the best care? Tell me, right? That doesn't feel too hard, right? And I'll say, tell me about 5 years ago. Tell me about 10 years ago, because what people are bringing to the snowball of end of life is a lived experience, right? They're bringing a whole, oops, that's not it. Okay, sorry. They're bringing a whole lived experience potentially of this, right? And we're getting them at one point in time in their life. And what you really want to know is, tell me what it's been like, right? Just tell me a story, share with me. Did you have, did you have a doctor in your 20s? Did you, whatever this was, right? You can imagine people who've experienced incarceration in their lifetime did not have access to healthcare. And we know that disproportionately African Americans are in the criminal justice system. And so being able to talk to people about their lived experience across an illness trajectory, tell me if you think you've gotten the best care, just to break the top off of it. And then tell me more, right? Good interview techniques, tell me more. We're going to get the courage to say, do you think that race had anything to do with it? We may not have the courage yet, the ability to, because, well, I don't know how to handle that. But I think if you can just ask people, telling their life story, they're going to tell you, you ask them about their history with heart failure, and they're just going to tell you maybe like what's been going on this month. You might want to know what's been happening, far, this is what you're trying to tease out. Because if your lived experience is this, you're talking to me now, Mr. S, about dying from heart failure, and there's nothing else you can do. And you're just going through your Kubler-Ross stages of grief, of anger, denial, bargaining, all of those things about how did I get here? How did I get here? And all we're doing is just trying to you're meeting that patient in the moment, but we need to be thinking on that long haul. So tell me if you think you've gotten the best care. That's a really, I think, easy, that's a low ball, soft question, that might seem accessible for folks, although it's not studied or tested. Okay, N equals 1. How about that? Thank you.
That's great. Dr. Quest, thank you.
All right.